Good afternoon, and welcome to the AMCP Science and Innovation webinar titled Chronic Hepatitis B from Diagnosis to Functional Cure, brought to you by GSK. Thanks for taking time out of your day to join us. My name is Andrea Craddock, Senior Manager of Education at AMCP, and I'll be your moderator. This presentation will be recorded and made available on AMCP Learn following approval from the sponsor. This webinar is sponsored, developed, and presented by the sponsor. The content of this Science and Innovation webinar and opinions expressed by the presenter are those of the sponsor or presenter and not of AMCP. At any time during today's presentation, we encourage you to type your question in using the Q&A button, which you'll see at the bottom of your screen. These questions are viewable only to the panelists. At the end of the presentation, we'll have a question and answer period. At that time, I'll read your question aloud over the line and allow for a response. Please note that some questions may not be asked due to regulatory or compliance reasons. It's my pleasure to introduce our speaker today, Sonal Kumar, MD and PH. Dr. Kumar is an assistant professor of medicine and is the director of general gastroenterology and hepatology at Weill Cornell Medical College. And now we'll begin our presentation. Dr. Kumar, the floor is yours.
Thank you so much, and thank you everyone for joining us today. So as mentioned, I'm going to be talking about chronic hepatitis B and really taking us through the entire disease spectrum, talking about diagnosis, talking about who's at risk for developing the disease, what is very specific to having a hepatitis B infection, and then how we monitor our patients and how do we decide who is a candidate for treatment and what are our goals of treatment for patients with hepatitis B, either now or in the future. Just the disclosure, this program is intended to provide disease awareness education. So when we talk about questions towards the end, only questions that we are able to answer are related to the disease state of chronic hepatitis B. These are my disclosures. You can take a look there. And so let's move into the program. Again, these are our objectives, and the talk is really separated into three different parts. So first, we'll talk about the epidemiology and disease burden of chronic hepatitis B, including how it differs from hepatitis C. I think because it's hepatitis B and hepatitis C, a lot of people, especially patients, lump them in together. So I think it's important that we really understand what the differences are in the viruses, and they're vastly different, and that really affects how we how we approach treatment for each individual virus. Then we'll talk about summarizing current screening, diagnosis, and management guidelines. And then finally, we'll recognize the challenges and unmet needs in the care of patients with chronic hepatitis B and talk really about what we should be striving for when treating these patients. All right, so let's start out with the first section, with the first objective. Let's understand chronic hepatitis B, and its burden. And what you'll see is throughout the program, we'll have knowledge check questions. And so this is like a sort of a pre-test question. If you guys could all answer those questions, and we'll hopefully teach it throughout the course of the program. And when we do the post-test, you all will get them 100% correct. So here's the first question. Number 1, chronic hepatitis B is diagnosed when hepatitis B virus infection persists for greater than 6 months, as confirmed by a positive Hep B virus test at least 6 months apart. Okay. True. Great. So when we talk about chronic hepatitis B and transmission, so this is hepatitis B it's a virus that really affects the liver, and when you get infected with the virus, you get acute hepatitis B, and then a certain percentage of patients will go on to develop chronic hepatitis B. And as was mentioned in the question, chronic hepatitis B is diagnosed when there are 2 tests that are at least 6 months apart that are consistent with having hepatitis B. Now, when we think about how people get hepatitis B, the most common route of transmission is vertical from mother to child, usually at childbirth when you get mixing of the maternal and fetal blood. Now, this is a virus that is transmitted from blood to blood, so you can get other ways of transmission. So exposure to other infected blood and bodily fluids, things like a needle stick injury, people who use drugs, sexual transmission. These are other routes of transmission, but by far what we see the most is vertical transmission from mother to child. Now, the risk of developing chronic Hep B infection, remember, not everyone that gets exposed to the virus goes on to develop chronic infection, but the risk of getting chronic infection is affected by the age at which you are exposed to the virus. And so if we think about an infant, greater than 90% of infants or children who are infected before the 1 year of age will go on to get chronic hepatitis B, and that goes down as one ages. So in a child from 1 to 5 years of age, up to 50% of children go on to develop chronic infection, whereas as an adult, if you're exposed to chronic hepatitis B, only 5 to 10% of otherwise healthy people end up getting chronic hepatitis B. Chronic Hep B is a big problem in the United States. It's thought that greater than 1 million Americans are currently living with chronic hepatitis B. In 2023, there was over 17,000 newly reported cases, and 47% of all of those newly reported cases occur in persons who are age 30 to 39 or 40 to 49. So there is, a little bit of an age demographic of people who are getting new infections. But there's also an ethnicity predisposition. So if you actually look at the breakdown of ethnicity in people who have chronic hepatitis C, you can see the majority of people are Asian. So 47% of people in the United States with chronic hepatitis B are Asian, then white, then black, and then so forth. And then about 77% of people who are in the United States with chronic Hep B are foreign born. So really important to think about this demographic when assessing patients and who is at risk and who should be screened. Now, the ethnic variations and disparities that we see, here you can see just a little more details about that. So the rate of newly reported chronic Hep B cases is highest in Asian and Pacific Islanders, followed by non-Hispanic Blacks, followed by non-Hispanic whites. And the unfortunate part of this is that Asian American and African or Black individuals also have a higher incidence and development of HCC at an earlier age. So not only are these the people that are getting hepatitis B, the ones that have hepatitis B already, especially in the United States, these are the people that are also at highest risk for disease-related complications. These are the ones that are going to get hepatocellular carcinoma. And that is one of the big concerns in people with hepatitis C, because as many of you may be aware, is that you can get HCC in the absence of having cirrhosis when you have chronic Hep B. Now, factors that contribute to the disparities that we see, the ethnic disparities that we see within chronic hepatitis B, include linguistic or cultural barriers, just lower awareness or perception of self-risk, socioeconomic status, insurance status, and gaps in physician knowledge on screening and guidelines for treatment. And so that just perpetuates the virus being transmitted from one person to the next. So speaking of transmission, which of the following is the most common route of hepatitis B transmission? Sexual transmission, perinatal transmission from mother to child at birth, needle stick injury, or blood transfusion? Perinatal transmission. Great. Now, all of these are actually modes of transmission, so you can get hepatitis B again from any of these modes of transmission, but because it is through bodily fluids and blood to blood, but perinatal transmission is the most common. Okay. So as I mentioned in the beginning, a lot of people lump hepatitis B and hepatitis C together. And sometimes you can see them together. Anywhere from 9 to 30% of people with chronic hep B are also infected with chronic hepatitis C. And if they have both hepatitis C and hepatitis B, it leads to increased risk of hepatocellular carcinoma. And that is essentially because you have two different viruses that are causing damage to the liver, that are accelerating the damage to the liver, and that increases the risk of liver-related complications. Now, with acute hepatitis B and acute hepatitis C, actually, patients may have mild to no symptoms. A lot of people will not remember how they got infected, when they got infected. It's just like having any other virus. So you may have some, feeling of not being well, but very few people can actually pinpoint the time they were infected with either hepatitis B or hepatitis C. And then once you develop chronic hepatitis B, often people are asymptomatic. The one thing that you can also see in Hep B, and we're not really going to spend too much time or a lot of time talking about this, but about 5% of hepatitis B patients are also infected with delta hepatitis, and that can also accelerate damage to the liver. And it is recommended that when someone with hepatitis B is diagnosed, that you also screen them for delta as well. But if you look at the differences between hepatitis C and hepatitis B, they're completely different viruses. So one is DNA and one is RNA when you think about the viral reproduction. So Hep C is an RNA virus. So when you actually check things like the hepatitis C viral load, you're measuring the RNA, whereas the hepatitis B, it's DNA. Routes of transmission, both blood to blood transmission, Hep B. We also say that you can get other bodily fluids. Risks of exposure, very similar risks of exposure, but again, the sort of the top cause is different for both of the viruses. So in hepatitis B, as we mentioned, it's perinatal transmission, but then below that, sexual contact, infected blood or bodily fluids, and sharing contaminated needles. Whereas when you think about the patient population that gets infected with hepatitis C, the number one cause of getting the virus is IV drug use. Other risk factors for risk of exposure to hepatitis C include history of incarceration, sharing contaminated needles, unprotected sex, especially in HIV positive men who have sex with men. So similar risk factors, but different. The order is a little bit different between the two viruses. Symptoms, again, a lot of these patients are completely asymptomatic. Things that you can sometimes see, jaundice, fever, fatigue, loss of appetite, dark urine, clay-colored stool. Jaundice usually occurs later in the disease and more with chronic liver disease or decompensated liver disease, but sometimes in the acute setting as well, patients can have these symptoms. When it comes to a vaccine, we do not have a vaccine for hepatitis C, but we do for hepatitis B. On the flip side, we do have a cure for hepatitis C, but we do not have a cure for hepatitis B. And we'll talk about why it's been really difficult to get a cure for hepatitis B a little bit later in the talk. Okay, so this is the structure of the virus. So I know this is a little bit complicated, but I think just big picture, looking at what the virus looks like, starting from the center, you have this core particle, and that's where the Hep B core antigen is. And so here, this gets infected into the individual, and this remains throughout the person's lifetime. So this is the core protein right here. And then you have this envelope that surrounds that core particle, and then you have the hepatitis B surface antigen domain. So and we'll go over how we interpret the test, but when we're talking about the presence of hepatitis B virus and how we're checking for that, you're looking for that hepatitis B surface antigen domain. But this will, even if the individual gets rid of or is able to clear surface antigen after being infected, that core DNA still stays in there and can reactivate. So if you look at the different proteins that are involved, I won't go through the fine details of everything, but here we have the hepatitis B surface antigen. And again, that is the Hep B envelope. And that plays a role in promoting immune evasion. And that's one of the unique things about hepatitis B is that it really affects the immune system. So part of the damage is not direct damage to the hepatocytes of the liver, but triggering the immune system as well. And this facilitates disease chronicity. Um, then there's the polymerase, and then there's Hep B E antigen. And this is a secreted viral antigen that's a diagnostic marker of high replication. So if a patient is HBe antigen positive, that means their viral replication is very, very high. And so these are the people that will have very high viral loads, and we can measure that in clinic. The Hep B core antigen, we talked about that. Uh, um, that's the core protein. And then we have the regulator of viral replication down here. Okay, and so what happens so with that sort of structure of the hepatitis B virus in mind, what happens when a person is infected with the hepatitis B virus? So first, the hepatitis B virus enters into the hepatocyte, into the liver cell, through receptor-mediated endocytosis. So it goes into the nucleus, you get this cccDNA, and this is what stays in the body, in the nucleus of a patient who gets exposed to the virus. So again, even if you're able to sort of quote unquote clear the virus once you're infected, this part of the virus will always remain. Then it undergoes viral transcription and translation, and then it goes out of the nucleus where it gets assembled into a viral particle, and then it gets released from there. So because of that structure of hepatitis B and sort of the pathway in which people are infected with the virus, hepatitis B is harder to cure than hepatitis C. And so just to sort of separate the different reasons into different category is that one is the viral DNA integration. So the Hep B virus actually incorporates into the hepatocyte genome, and it's really hard to get rid of that once it's already integrated. And then you have that cccDNA. Again, if a person is exposed to the hepatitis B virus, that cccDNA remains permanently in the hepatocyte's nucleus. And as long as it's there, it can be stable and it can cause no symptoms whatsoever, and doesn't cause any damage to the liver. However, it is a long-lasting template for viral replication. And so if the cccDNA is there, normally the host immune system will keep it at bay, but in patients who get some sort of immunosuppression, that's when you worry about the risk of reactivation and complications from that. And then immune evasion. So hepatitis B has mechanisms to evade the host immune system. So this is what I was talking about. Not only, one of the unique things about hepatitis B is that it really affects the immune system, and so it includes inhibiting CD4 and CD8 T cells. And so putting these all together, it makes it a lot more difficult to cure compared to hepatitis C. So shifting gears a little bit, who should we be screening for hepatitis B? It's a common problem in the United States. We have over 1 million people in the United States with hepatitis B. We're still getting new infections. So who should we be screening? So the CDC in 2023 put out an update that recommends that all adults at 18 years old or older should be screened at least once doing a triple panel test to identify those with an active infection. And so that triple panel test is a hepatitis B surface antigen, anti-hepatitis B antibody, so an antibody to hepatitis B, and then a total anti-HB core, hepatitis B core antibody. And that's the initial screening. And we'll go through a little table that'll show how to interpret those tests. But basically, if they have active infection, the hepatitis B surface antigen will be positive. If they've ever been exposed, the core antibody will be positive, and if they're immune or vaccinated, the surface antibody will be positive. So that's the triple panel test. It's really easy to order. It should be in all EMRs or easily ordered. And every adult really should be screened at least once. On top of that, you should screen all pregnant persons using that triple panel test during each pregnancy, regardless if they've ever been vaccinated or of their history of testing. And that's really because the number one way that we see hepatitis B being transmitted is from mother to child. So we really want to be sure that we know the hepatitis B status of every pregnant woman out there so that we know how to handle it when they're delivering. And then expand risk-based testing. So there are people who will have risk factors for getting hepatitis B and not being pregnant, whatever, they have multiple sex partners, they have a history of sexually transmitted infections, etc. Or if they're born in those highly prevalent regions where hepatitis B infection is greater than 2% or 2% or more. Those are the people that you want to just expand the testing. So you may do it more regularly, you may do it annually, you may do it every 5 years, etc. And that can be done, that can be decided on an individual basis. And then anyone who asks for testing, regardless of disclosure of risk, we don't necessarily need to know that, but if someone comes in asking for the hepatitis B test, we should be doing it. So here's the table of how we interpret the tests. So number one is the acute infection. So when you're exposed to the virus, your hepatitis B surface antigen turns positive, your core antibody turns positive, and then your core antibody IgM also turns positive. So again, this is the core antibody being positive, the total antibody being positive just shows that someone has been exposed to the virus. When the IgM is positive as opposed to the IgG, that's when it's an acute infection. And those are people that should be linked to hepatitis B care. If they have a chronic infection, again, their hepatitis B surface antigen will still be positive. Their anti-HB core antibody will be positive. That again means that they've been exposed, but their IgM will be negative. So these are the people who have gotten through the acute phase but now have developed chronic infection. They should also be linked to hepatitis B care. If someone is exposed but didn't develop chronic infection, their surface antigen will be negative, core antibody will be positive, and then their surface antibody can be either positive or negative. These are the patients that we really counsel about risk of reactivation. Again, if they're immunosuppressed or they're getting chemotherapy or something, you can get reactivation, and so we want to be mindful of that. But outside of that, it shouldn't really cause any issues. If someone is immune from vaccination, their surface antigen will be negative, their core antibody will be negative because they've never been exposed to the virus, and their surface antibody will be positive. And then if they've never been infected, but they are susceptible to the infection, everything will be negative. And these are the people that we should offer the hepatitis B vaccine as per guidelines. So once you diagnose someone with hepatitis B, the next step is really to get a full medical history, physical exam, etc. Now, physical exam could be completely normal, and in most of my patients with hepatitis B, it is completely normal. You would never know; they don't have any symptoms. Walking, talking, and that's why it's really important that we know who should be screened and how to screen these people, because we really want to make sure that we identify who needs to be monitored from a hepatitis B standpoint. But sometimes they can have physical exam findings, and most of the findings that you would see on physical exam would just be more consistent with more advanced liver disease. So if they have jaundice, ascites, splenomegaly, If they have pulmonary edema or their hands are red, or you see some spiders or caput medusa, gynecomastia, if they have encephalopathy, these are all just symptoms of decompensated liver disease. And so we have to just recognize that these are signs of decompensated or more advanced liver disease. And these are the people that really need to be in the hands of potentially a transplant institution so that they can be further managed. When you take a medical history, we want to assess for risk factors so we can address any risk factors. We can counsel our patients on how they should treat, the other people in their family, etc. And so we ask about risk factors and potential other exposures. When you check lab tests, sort of standard baseline lab tests, you want to check liver enzymes. We check a hepatitis delta total antibody to make sure they're not co-infected with hepatitis delta. Check an INR to see if their liver function is intact. Otherwise, just kind of standard labs. And we do want to get some assessment of fibrosis. And so, a lot of people will get liver stiffness measurement or fibrosis assessment. Things like transient elastography are really good non-invasive tests. We don't typically do a liver biopsy unless there's some question about the disease, especially in patients with hepatitis B. And then a full abdominal ultrasound. And this should be done fairly regularly in patients with hepatitis B because there is a risk of hepatocellular carcinoma and they need to be screened. Okay, so when a patient has hepatitis B, you further divide them into what different phase they're in. And we used to have these different categories or these different names for the infection. So there was the immune tolerant phase, immune active phase, inactive carrier, and reactivation. And we've really gotten away from those specific identifiers, partly because there's different people mix them up, but also there's some, uncertainty sometimes in where a patient falls. But we really use chronic hepatitis B infection or chronic hepatitis B. And so, but we'll go through the different phases of infection. So this is phase 1. And so this is where you will have a high HBV DNA. So there's a lot of virus in the body, but it's actually not causing much damage to the liver. So ALT is pretty normal. So if you were to do a liver biopsy on these patients, again, not saying that we do liver biopsies, but if you were to do a liver biopsies on these do a liver biopsy on these patients, you would see little to no inflammation, no fibrosis, but they do have a high level of DNA. And these are people who will have the HBe antigen being positive. And again, the HBe antigen positivity is a marker of really high viral replication. So anytime you see the e antigen being positive, they often have really, really high viral loads, like over 20,000. So then we move on to phase 2, and this is what was immune clearance or immune active phase. And this is where the viral load actually starts to drop a little bit, but can sort of fluctuate over time. But they do have an elevated ALT. And so these are people who will have liver inflammation. If you were to do a liver biopsy, they can get fibrosis in these settings. And so if they have an e antigen that's positive and a high viral load, these are patients that it would warrant treatment for. Then we have phase 3. So you lose that e antigen. So that e antigen turns negative and you have chronic hepatitis B infection. And these were people that were in the past known as inactive carriers. So you lose that high viral replication, the viral load drops. Because you don't have that high viral replication and you don't have that response from the hepatocytes, the ALT also goes down. So these are patients that have normal ALT and they have a low viral load. And these are patients that don't really need treatment if everything stays low. Again, ALT normal, and usually the viral load is less than 2,000. and their e antigen is negative. But they can get some sort of reactivation. So sometimes, even in the Hep B e antigen negative patients, you get this response where the ALT actually goes high and the viral load goes higher. So you move into this phase 4, and it's hepatitis B e antigen negative chronic hepatitis B. And so you have a higher viral load, not as high as when the e antigen was positive, but it's paired with a high ALT, and so that's where these patients would also be candidates for treatment. And then finally, if you're lucky, phase 5 is when you lose the surface antigen. You still will have that core antibody that's positive, and you may or may not get a surface antibody that's positive, but this is also known as a cult hepatitis B infection. So depending on which phase people are in, there's different criteria for how you treat them or who should be treated. So here, surface antigen positive, someone has hepatitis B, then you look at their e antigen. So that's the next step in the algorithm of when deciding who should be treated and who could be monitored. Now, if their ALT is normal and their viral load is high, it's easy. Again, these are the ones with high replication, but they don't have liver damage. And if you were to do that biopsy, you wouldn't see anything significant. So these are the patients that you do not want to treat. You just monitor the ALT and viral load levels every 3 to 6 months, and check their e antigen levels every 6 to 12 months. Now, on the flip side of it, if their ALT is greater than 2 times the upper limit of normal and their viral load is high, these are the ones that are in phase 2. So these are the ones that have that high viral load, but they also have damage to the liver. So these ones are easy. So these are the patients that you do want to initiate treatment with. But then there's this gray zone. So ALT may be elevated, but not as high, less than 2 times the upper limit of normal, but their viral load is high. And so these are the patients that you want to exclude other causes of ALT elevation. Just throwing it out there, MASLD affects 30% of the population. So you want to assess their risk factors for something else causing the ALT elevation, not the hepatitis B virus. And assess disease severity. So if you were to do transient elastography on a patient or a liver biopsy on a patient, this is where a liver biopsy may be useful. If there's evidence of fibrosis, then you want to start treatment on these patients. The other time to consider initiating treatment if their age is over 40. And these are the ASLD guidelines for if the e antigen is negative. So again, surface antigen positive, e antigen negative. If the ALT is normal and the viral load less than 2,000, easy. If the ALT is over 2 times the upper limit of normal and the viral load is high, easy, you treat these patients. And then you have all these gray zones, right? The ALT is elevated, but the viral load is not higher than 2,000, or the viral load is higher than 2,000, but the ALT is normal, or somewhere in between. And again, these are the patients that you want to monitor a little bit more closely, every 3 months maybe, and then every 6 months. You want to look for other causes of ALT elevation, and then you want to assess disease severity with non-invasive tests if available. And again, if there's evidence of fibrosis, recommendation is to err on the caution and treat these patients. Just a caveat, these guidelines are being currently updated and hopefully we'll have new ones out there, but this is the general rule of thumb. And when we see these patients, right, if there's evidence of liver inflammation, there's evidence of liver damage through just blood work and their viral load is high, you treat them. If the viral load is low and there's no evidence of liver damage, you don't treat them. And then sort of in those in-between stages, you really have to look for other causes of liver disease and really take it on an individual basis. And this is where we really do shared decision-making, really have open discussions with the patients on the risk and benefits of treatment. So when we talk about treatment, there's still a lot of unmet needs for people with chronic hepatitis B. Now, what we have, the nucleoside analogs that we have available for patients, they're not a cure. They help suppress the HBV DNA, so you can get the viral load down, but there's still a risk of hepatocellular carcinoma. And if you're able to, get viral suppression, it does, reduce that risk significantly, but it doesn't go away. And so now we've really shifted to thinking about how can we make this really positive for patients in terms of treatment. What should be our goals of treatment? Not just viral suppression. We want to really reduce that risk of HCC. We want to cure hepatitis B as much as we can. And so there's this definition of functional cure. So functional cure is a sustained undetectable serum hepatitis B surface antigen and DNA with or without seroconversion to surface antibody after a finite course of therapy, but you'll still have that residual CCC DNA. And with this comes resolution of liver injury. You sort of eliminate that gray area of where we treat versus we don't treat, and there's a decreased risk of cirrhosis and HCC and all liver-related complications. So you can take a step back and sort of look at the big picture of what our goals are in terms of treatment for people with hepatitis B. Ultimately, we want to prevent the progression of fibrosis. We want to prevent liver-related complications, including hepatocellular carcinoma, and we want to reduce morbidity and mortality. That goes for any liver disease, and it's no different for hepatitis B. But when we talk about achieving that in hepatitis B, we have sort of different components. Number one, we want to get rid of the hepatitis B virus, right? So we can do that with the nucleoside analogs. We can suppress the virus right now in a majority of patients. We want to reduce liver damage. We want their ALT to normalize so that, not 100%, but in general, ALT is a marker, especially in hepatitis B, of damage to the liver. And then ideally, it would be nice to have the surface antigen go away as well. It's highly desirable, but right now what we have, it's real with the treatments that we have out there right now, it's not easy to achieve that. So let's talk a little bit more detail about that functional cure, about losing that hepatitis B surface antigen and what we need and how we can maybe achieve it. So this is question number 3. Which of the following best describes a functional cure for chronic hepatitis B? A, complete eradication of all HBV DNA from the body, virus completely eliminated. B, sustained undetectable serum HB surface antigen and HBV DNA after a finite course of therapy with or without seroconversion to surface antibody, so virus controlled without ongoing treatment. C, suppression of HBV DNA while continuing lifelong therapy. Or D, normalization of liver enzymes only. Okay, great. I feel like you guys all know this. All right, so let's explore functional cure a little bit more. So, again, hepatitis B is a potentially life-threatening form of viral hepatitis. It affects millions of people worldwide, greater than 1 million people in the United States. And successful treatment, we talked about in this couple of slides ago, undetectable HBV DNA, normalization of liver enzymes, and then ideally surface antigen loss. And then our ultimate goals are prevent fibrosis progression. We really want to prevent liver-related complications, including HCC, and reduction of morbidity and mortality. So when we think about these different definitions of cure, so I'm talking about functional cure, which is atypical to achieve with what we have currently available. But there are other definitions of cure, and I think it's important to recognize what, you'll see these different terms thrown around when we talk about cure of hepatitis B. So I think it's really important to understand what that means. So first we have partial cure. So partial cure is really what we do right now. We get the HBV DNA undetectable, we get the ALT normal, but you still have detectable hepatitis B surface antigen. So the current nucleoside analog therapy that we have, we can get that partial cure. But this is a lifelong medication, so people do continue to take the medication. Then we have the functional cure. We talked about this already, but it's a finite course of therapy. The CCC DNA would still be there because we can't target that yet. But the surface antigen would be gone, and we can't really get that right now. And then complete sterilizing cure. And so that would be completely eliminating not only the surface antigen, but HBV DNA, as well as losing that CCC DNA and that integrated DNA fragment. So right now there is no way to achieve that. We cannot target that CCC DNA to remove it essentially from the nucleus of the hepatocytes. So the barriers that we have are really current therapies and their ability to achieve functional cure. So the two therapies we have out there are nucleoside analogs. Those are the oral pills, and the surface antigen clearance rate. So achieving that functional cure occurs in 1% or less with the nucleoside analogs. And then also some people still use interferon, so PEG interferon. It occurs in 2 to 8% of patients. And so really, really hard to achieve that functional cure, even though that it has really shifted to be to our goal in treatment of patients. Other barriers, a high viral load and the antigen burden, impaired host innate and adaptive immune response against hepatitis B. Again, remember that the hepatitis B virus affects the immune system, and that CCC DNA is very difficult to target. Okay. So here we've talked about this already, but just to know that functional cure, not only it's a finite amount of treatment, and then 24 weeks following the cessation of all treatment, if the Hep B viral load is still undetectable and the surface antigen is also undetectable, that is considered a functional cure. And so if you actually just look at what happens, here you have when you have viral suppression on therapy, the surface antigen is positive. When you get a functional cure, the surface antigen goes away. And then if you get a complete cure, that's where, we're saying that that sterilizing cure, it would be getting rid of the CCC DNA as well. Okay. So why do we want to shoot for functional cure as opposed to viral suppression? And so part of it is that it reduces the risk of liver-related complications. So if you actually get that functional cure, it's the same as basically saying that someone was exposed to the virus, but they were able to clear the virus. Yes, they still have the CCC DNA in them, but the risk of liver-related complications is essentially eliminated. And it's after a finite amount of therapy. So you don't need to continue therapy in order to be in sort of that state of not having any effect on the liver. So you really can avoid the long-term treatment. You don't need long-term monitoring. You don't need long-term testing. And then it helps with the costs of long-term therapy. These medications are often not cheap. And so achieving that functional cure eliminates the need for long-term medications and the costs associated with it. But from a patient perspective, also, it may reduce the risk of transmission and the stigma associated with hepatitis B. And then because the hepatitis B virus affects the immune system, you get recovery of the HBV specific immune function. And both the EASL, so the European guidelines, and the AASLD-EASL combined guidelines see functional cure as an endpoint for novel investigational therapy. So drugs that are in development, functional cure should really be the goal. And EASL goes as far as say that functional cure should be the ultimate treatment goal in these patients. So again, from a patient perspective, finding therapies for chronic hepatitis B that induce a functional cure, reduce the pill burden. We know that people take a lot of medications, and if you are able to, eliminate one, that is very, very important. It reduces the costs associated with indefinite nucleoside analog treatment. Right now, when I'm putting someone on hepatitis B therapy, I tell them that this is a lifelong medication. It reduces the physical burden on patients. It reduces the negative perception of having the disease, of taking treatment, and the daily reminder that they actually have hepatitis B. And when you ask patients about this, they feel the same way. In chronic hepatitis B induces a lot of anxiety and can induce a lot of worry in in patients that have it. There was a survey of over 1,700 participants with chronic hep B, and about 50% say that they worry about the development of liver cancer or living a shorter life. And then other interviews with participants, 79%. So the majority of patients do describe experiencing social stigma. And this is a quote that I thought was really, really nice. But a functional cure would make me a lot less anxious about my future. I would not have to rely on daily pills anymore. I'd feel more assured that I would have smaller chances of developing liver cancer throughout my life. And so even if you take the liver related events out of it, even if you take the risk of HCC, the risk of fibrosis, the risk of all of this stuff, from the patient's perspective, they're the ones who have to really live with this day in and day out. And this is a huge impact. If they don't need to be monitored for hepatitis B, they don't need to take lifelong medications, they're not worried about the risk of liver cancer, it really can affect patients' quality of life. And we have to keep that of equal importance when we're making decisions. Um, so again, when talking about functional cure, Hep B surface antigen loss is a critical component. It's that surface antigen loss that really allows us to sort of take a step back and understand that these patients are no longer at risk of all of the complications of having hepatitis B. It really eliminates that risk, that monitoring, then just having viral load suppression. So when you talk about, again, just sort of differentiating it from hepatitis B and hepatitis C. Now, hepatitis C, we talked about how the virus is different, and it's an RNA virus. It does not integrate into the genome or the host DNA, and so achieving a cure in hepatitis C is much easier than it is when it comes to hepatitis B. Once you get rid of viral replication and the virus is cleared from the body, hepatitis C does not reactivate because there's no viral fragment there. It's much easier. It's not in the nucleus of the cell. It's in it's much easier to target. And unless the patient gets reinfected, they're not going to have hepatitis C again. And there you can actually get a complete cure. Whereas in hepatitis B, because of the structure of the virus, because of that, how the sort of the process of getting infected goes, it's really hard to eradicate all of that. So that's why we consider the functional cure a cure, as we can't get rid of all of those reservoirs of hepatitis B virus. And this is just showing that sort of the differences, the viral family, again, RNA versus DNA. Hepatitis C is only in the cytoplasm, whereas Hep B is in the nucleus and the cytoplasm. And it's that nucleus that really affects our ability to get a complete cure. And then persistence with treatment is low, now with DAA-based therapy, but in hepatitis B, it's still high. And so when we talk about functional cure, the three components that we want, you need to inhibit the B replication. So you need to get the viral load down. You need to suppress antigen production from the ccc DNA and integrated DNA, and then restore the immune response. And when you get all three of those together, that's when you can get that functional cure for chronic hepatitis B. Okay, and I think this is the last slide. So just to summarize, I know it was a lot of information, but majority of people with living with chronic hepatitis B in the United States are foreign-born individuals. So when you think about different patients that are at risk for getting hepatitis B, keep that in mind, especially the ethnic variation that we see in people with hepatitis B. No matter what the ethnicity is, no matter what your risk factors are, everyone should at least be screened for hepatitis B once, all adults. And then you should use the triple panel to screen for those patients. And if they are not vaccinated, they should get vaccinated. Now, ultimately, our goal as providers for our patients is to prevent the progression of fibrosis and reduce the risk of liver-related complications, and especially hepatocellular carcinoma when it comes to hepatitis B, but cirrhosis, liver failure, need for liver transplant. Hepatitis B surface antigen levels in particular can be used as a marker to monitor disease, determine prognosis, and guide treatment decisions. And surface antigen clearance is associated with reduced risk of long-term adverse clinical outcomes, including hepatocellular carcinoma. So with that, functional cure is our goal of chronic hep B treatment, but right now we don't achieve it that frequently with the current therapies that we have available. All right. So now, I mean, you all got these questions right to begin with, but we'll have you do these again. These are the post-test questions. So hopefully no one gets them wrong now, because then I really did not do a good job. But post-test question 1, chronic hep B is diagnosed when hep B virus infection persists for greater than 6 months, as confirmed by positive hep B tests at least 6 months apart. So at least 2 tests 6 months apart. Does that mean that are positive? Does that mean you have chronic hepatitis B? True or false? Yay. That is true. Next question. Which of the following is the most common route of transmission for the hepatitis B virus? Sexual transmission, perinatal transmission, needle stick injury, or blood transfusion? All right, perinatal transmission. Great. Again, that is correct. Again, you can get hepatitis B from any of these routes of transmission, but perinatal transmission is the most common. Number 3, which of the following best describes a functional cure for chronic hepatitis B? A, complete eradication of all hep B DNA from the virus. B, sustained undetectable serum hep B surface antigen and hep B DNA after a finite course of therapy, with or without seroconversion to hep B surface antibody. The virus controlled without ongoing treatment. C, suppression of hep B DNA while continuing lifelong therapy. And D, normalization of liver enzymes only. Great. Yep, so sustained undetectable serum hep B surface antigen and viral load after a course of therapy. And then if 6 months afterwards that still persists, that is the definition of a functional cure. Some people may get anti-hep B, may develop surface antibody, but either way, it's considered a functional cure. And with that, I will take any questions.
Great. Thanks, Dr. Kumar, for that presentation. We will now open the floor to your questions. Remember, you can submit a question using that Q&A button, which you should see on your toolbar. Our first question is, what is the significance, if any, of the LMS surface antigens?
I'm not sure, the LMS?
M and the S.
I'm not sure what that's referring to. Let me go back to the slides on the different surface antigens. There are different components to the surface antigen. Let me see if I'll go back. Let me go back to the virus slide. Oops. So these are just different components to the surface antigen. These are not actually, so this entire thing, they're different proteins that comprise the surface antigen. It's like the entirety becomes a surface antigen. These are not things that we can detect in the lab. So when you're actually checking for this, it just checks for surface antigen as a whole, but these are the different proteins that make up the entire surface antigen.
Great, thank you. Our next question, for goals of CHB therapy, why is HB surface antigen loss important to achieve in addition to undetectable HBV DNA?
Right. So the advantage of achieving a functional cure in hepatitis B and getting rid of that surface antigen is that you can take patients off therapy, and they are essentially the same as someone who has been exposed to the virus, but was able to essentially fight off the virus and doesn't have chronic infection. So you eliminate the need for hepatocellular carcinoma screening. You eliminate the need for long-term monitoring. These are patients that do not need lifelong therapy, but still don't have the risk of liver-related complications. Now, with the loss of the surface antigen, again, you still have that cccDNA, and it's important to recognize that that comes with the functional cure. You still have that component, so you still need to talk to a patient about reactivation, but actually the risk of liver-related complications really goes away.
Thank you. Do we know why some people are able to achieve functional cure and others are not?
Yeah, I mean, that's a really good question. And it's hard because the functional cure is the rates are so low. The current therapies that we have available, for the most part, we use nucleoside analogs as treatment for people with hepatitis B. I think it's got to be a multifactorial thing, but probably the host. There's something about the host that allows you to lose surface antigen. But I've been treating hepatitis B for almost 20 years now, and I probably have 10 or less patients that have lost surface antigen with just either no therapy or with nucleoside analog therapy. And it's so few numbers that we can't like group them together, but it must be something about the host immune response that allows you to fight off that antigen and lose that antigen and achieve the functional cure.
Thank you. So when can we consider discontinuing the treatment?
For nucleoside analog therapy, it is considered a lifelong treatment. Majority of people that you try to take off therapy, even if they've been on nucleoside analogs for a long period of time, they will end up flaring and their viral load will go up and will often need to go back on therapy. So when we think about of the treatments that we have available right now, it should be considered a lifelong therapy and you would not discontinue treatment. And that's part of why we want to achieve that functional cure. So we give that option to patients to come off of therapy.
Do you know what percentage of patients have co-illnesses of CHB and either MASH or HE?
That's a good question. I don't actually know the numbers of co-infection with MASH. The 30% of the population has MASLD, and about a quarter of those will have MASH. So it's going to be high, and I think that's a really important part to recognize when we look for other disease causes. When we see someone with an elevated ALT. Um, we have to keep MASLD and MASH really high on our differential of why the ALT is elevated. And that's why sometimes in these cases you will end up doing a liver biopsy because you really need to figure out what's causing the inflammation and what's causing the damage to the liver. Having said that, having two coexisting diseases can accelerate the damage to the liver. So I think these are the patients that we have to pay particular attention to and make sure we follow them regularly and potentially even be more aggressive in our treatment, both from the hepatitis C and from the mast cell standpoint. Because, just like alcohol and Hep B, alcohol and any liver disease, or Hep B and Hep C, co-infection accelerates liver damage. The same thing happens with any other liver disease.
Thank you. Why do some patients seroconvert and others do not?
I think this is the same answer as last time. It's hard to say. Age definitely plays a factor. So the age at which you're exposed. But when you talk about adults, in terms of seroconverting, it's got to be something with the host, with the individual that is allowing them to seroconvert, and it probably has something to do with their immune system.
Does HBV liver damage commonly affect the gallbladder and pancreas? For example, complex biliary complications.
I don't think so. I don't think there's any major association with gallbladder and pancreas when it comes to hepatitis B. Now, if they have like advanced liver disease, yes, but not directly from hepatitis B virus.
Thank you. I think we have time for just one more question. In a patient who has achieved a functional cure of HBV, but also has now been infected with chronic HCV, would you recommend restarting HBV therapy when HCV therapy is initiated?
Okay, so they've been infected with chronic hepatitis C, but they have a functional cure. So if they have a functional cure, then they shouldn't have hepatitis B virus in them, and they should be just similarly treated as someone who was exposed. So they would just be Hep B core antibody positive. And so this is something that, we do check in people who have been diagnosed with hepatitis C, because when you're starting DAAs, there is a risk of reactivation of hepatitis B in patients who are being treated for hepatitis C with DAAs. And so you do need to monitor them, but if they have undetectable viral load at baseline and a surface antigen that's negative, I probably would not necessarily initiate treatment. And that's pretty consistent with the guidelines, but you would follow them to make sure that their viral load stays negative.
Thank you. We are all out of time for today, so I'd like to thank you, Dr. Kumar, for speaking, and thanks to our sponsor, GSK, for providing the webinar, and thanks to each of our attendees for joining us today. Please be sure to look at our list of upcoming webinars at amcplearn.org. And that concludes today's program. Thank you.
Thank you.